sure to email a copy to everyone, hopefully by tomorrow. And now I would like to turn everything over to Dr. Arnie Advincula.
Thank you, Alyssa, and good evening, everybody. My name is Arnold Advincula, and I'm the Chief of the Division of Gynecologic Specialty Surgery at Columbia University Medical Center. And basically in honor of Endometriosis Awareness Month, it really gives us great pleasure to be able to host this webinar on endometriosis, a path forward for patients. And without much delay, what I'd like to do is jump right into introducing our esteemed panelists this evening. These three individuals are partners within the division who bring to the table a wide variety of skill sets and clinical expertise to the subject of endometriosis. The first person is Dr. Hye-Chun Hur, who is a fellowship-trained minimally invasive gynecologic surgeon, followed by Dr. Jin-Hee Kim, also a fellowship-trained minimally invasive gynecologic surgeon with an expertise in endometriosis as well. And rounding out the panel is Dr. Beth Rackow, who brings some unique skills to the table because of the fact that she sort of straddles two or three basically areas of expertise, one being reproductive endocrinology and infertility as a board certified specialist in that arena, in addition to a minimally invasive gynecologic surgeon and an expert in pediatric and adolescent gynecology. And so hopefully this evening, after some brief remarks from the three of them, we can entertain and hopefully have a robust discussion regarding endometriosis. And we are certainly open to any questions live on the air, as well as we will try to answer some of the questions that were sent in ahead of time. And so I'm going to turn things over to Dr. Hur.
Good evening, everybody. So let me get to the slides. So the objectives of this next hour will be specifically discuss, well, what is endometriosis, and to address the question of how is endometriosis diagnosed, how does endometriosis present itself, both with clinical symptoms and manifestations, and how do we treat endometriosis? To jumpstart this discussion, we're going to go over the definition of endometriosis, which is when endometrial tissue, meaning the tissue lining the uterus, so it's what we shed once a month for our period, presents beyond the uterus. Now, these implants can most typically manifest in the pelvis, as you can see here, on the pelvic side wall, or maybe deep in the posterior pelvis. But it can also implant on the ovary tube, or somewhere in the abdominal cavity, anywhere in the abdominal pelvic field. It's an inflammatory condition. It's estrogen dependent, so it specifically affects women in the reproductive age group. How is endometriosis diagnosed? It's a clinical diagnosis, it's a surgical diagnosis that's diagnosed at the time of surgery, specifically called laparoscopy, where the laparoscope here penetrates in through the belly button, and under magnifications of this camera, you can see special implants. Ideally, these implants should be excised if you have a tissue diagnosis. The surgical manifestation of endometriosis can be very varied. The most classic presentation is what we call these black powder burn lesions, but they can also manifest as white scarred lesions or vesicular lesions. And the only point in sharing this detail is that endometriosis can sometimes be difficult to diagnose, even for the surgeon. Endometriosis can also implant in the pelvic organs themselves, where it implants on the ovaries, called endometriomas, or on the uterus, called adenomyosis. How does endometriosis clinically manifest? There's two main clinical buckets. It can manifest as pelvic pain, or it can manifest as infertility. And often treating and managing the pain component or the infertility component can be technically challenging and often a tug of war. If we treat pain, often we suppress the hormones and stop fertility. And if we support the fertility goals, it often flares the hormones and can aggravate the pain. This is our segue to our fertility specialist, Dr. Rackow, who will go on to talk about endometriosis and fertility.
Thank you, Dr. Hur. So we know that endometriosis affects about 10 to 15 women of reproductive age. So we see this from women in adolescence and through their reproductive years. We know that of women with endometriosis, about 30 to 50% are estimated to suffer from infertility. And of women who present with infertility, we know that a reasonable proportion, potentially a quarter to a half of those women, might have some form of endometriosis. So clearly we understand that endometriosis has significant fertility implications. Next slide. So how does endometriosis impact fertility? Well, there are a few specific issues that we're concerned with. As Dr. Hur just mentioned, endometriosis causes inflammation. And so there's an inflammatory response in the pelvis. And there is concern that this can impair both the lining of the uterus, the endometrium, as well as egg quality. There's disruption and distortion of pelvic anatomy. Endometriosis as part of this inflammatory condition can cause scar tissue. And so it can both damage fallopian tubes, damage ovaries, pull structures geographically away from where they should be that enables sperm and egg to meet each other. And so the disruption and distortion of pelvic anatomy is a significant condition that we deal with, especially the more advanced the endometriosis, and also can cause abnormal development of eggs and potentially abnormal fertilization of the eggs. And again, this is thought to be sort of a direct effect of endometriosis on the quality of eggs. Next slide. So how do we evaluate infertility for patients where this is a concern? So the things that we pay attention to are, first of all, the ovarian reserve. And this is one of the key concepts, that women are born with all the eggs we're ever going to have, and we lose eggs every single month, whether we're pre-puberty, during puberty, on birth control pills, pregnant, we're always losing eggs. And so the question is, when someone presents for infertility evaluation, can we test for the quantity of eggs remaining in the ovaries? We can't really test for quality. The best marker is truly a woman's age, but we pay attention to egg reserve. We pay attention to pelvic anatomy, looking at the uterus, the ovaries, the fallopian tubes, looking for, are there cysts on the ovaries? Are the fallopian tubes normal or abnormal? Is there anything wrong with the uterus? And of course, if there is a male partner, a semen analysis to assess the male as well. But the other thing we always have to pay attention to is the presence of dysmenorrhea and pelvic pain. For some women, their presentation with infertility and pain might be the first time that we identify endometriosis. But we all know that there are women who present with endometriosis with infertility alone without having pain, but we have to pay attention to the concept of pain. Next slide. So just a few thoughts about treating endometriosis in women who have infertility. So our treatment's really guided by sort of the number of infertility factors we identify. Either is it endometriosis alone or other things within the male or female. We have to pay attention to the age of the female, the reserve of eggs that she has in her ovaries. And we know that the severity of the pain may necessitate different or more aggressive treatment. Many women don't necessarily need surgery before infertility treatment, but if they can't handle their menstrual cycles and the fertility treatment, sometimes those patients absolutely need surgery before they can move on with infertility treatment. And then just the concept of fertility preservation for patients who have significant endometriosis and need to preserve their fertility for the future. It's another topic that we talk to patients about, both either freezing eggs or freezing embryos. I'd like to pass on to Dr. Kim, who's going to take over the next section.
Great, thank you so much. So just to continue on what Dr. Hur and Dr. Rackow had been mentioning about endometriosis and treatment, there's certainly a whole range of options. However, as we all know, that treatment itself is quite challenging at times. And so that I think that that tug of war that Dr. Hur mentioned with treating the pain versus infertility and sometimes treating both can be quite challenging. But in our armamentarium, we have some medical treatment options and surgical treatment options. And in terms of medical treatment options, there are some limitations, as it are mostly targeting hormonal, the hormonal pathway. So there's some contraceptive effect. And surgical treatment wise, there's different types that we'll get into a little bit more detail. But generally, there's more conservative options where we remove visible disease, and maybe more quote unquote definitive. And I don't really like to use that word because certainly in medicine, not everything is quite definitive. But perhaps targeting more the hormonal source with the ovaries producing the estrogen, that may be one of the possibilities. But I think it's really important to note that treating any coexisting conditions, because as we all know, endometriosis can coexist with other pain syndromes that involve the gastrointestinal system, urologic system, musculoskeletal, et cetera. So it's easy to be sort of trapped in this mindset of my pain is all endometriosis, but in fact, it can have multiple reasons. So to work with multiple other specialties, if indicated, I think that's also very important. Next slide. This is a busy slide, but just in terms of medical treatment, we do have general categories, and I also didn't mean to leave out the non-steroidal anti-inflammatories, which target the inflammatory response. And the list here is a summary of the hormonal treatment options. And brief category-wise, there's the estrogen progestin options, as we all may know, more the birth control pills or the patch or the vaginal ring. The progestin category includes, maybe you've heard more of the Provera or Agestin, or Depo-Provera, the injection, the implant, Nexplanon, levonorgestrel IUD. There are different kinds. And then there's another category of what we call GnRH analogs, which target the receptor, the gonadotropin releasing hormone receptor, where in both of these, it alters the hormonal pathways to further decrease the estrogen level to target endometriosis therapy. But the take-home point is that there are different types of treatment options with different routes and different frequencies. So all of them may have a side effect profile that may work for some, but not others. And then I also included letrozole, or the category of aromatase inhibitors, which is technically not FDA approved, but has been used in clinical practice. And I grayed out the androgens, which have been used many, many years ago, but not so much anymore just because of the side effects. Next slide. Surgical treatment options, as we have discussed, there are different types, and just brief categories include the excision removal of endometriosis implants, or ablation is the cauterization. We do favor in our practice excision when possible. Removal of an ovarian cyst or ovary or fallopian tube. This is depending on where the endometriosis actually is. Hysterectomy with or without ovary removal is certainly an option, not the only option. And I think part of this discussion is that we want to highlight how we have non-hysterectomy options available. You have to also take into consideration that endometriosis can implant in other organs as well. So sometimes surgical treatment includes other organs such as bowel or bladder. And in terms of the modality or the route of surgery, minimally invasive surgery that includes laparoscopy or robot-assisted laparoscopy is generally favored versus the open approach. Next slide. And the reason is because there are certainly benefits of this approach. So you may all be aware with the minimally invasive approaches that there is faster recovery, less post-op pain. It's an outpatient procedure typically, and cosmesis, and decrease other perioperative complications, including blood loss, infection, and scarring. So I think I just want to conclude by saying that there are treatment options that we have in our armamentarium, but some may not be for everyone. And I think this is more of a message that we have different options, and we do have to tailor it to the individual patient, taking into consideration the history, the exam, and where exactly the endometriosis and what other coexisting conditions there are. So hopefully we can answer some of your questions, and I'm going to give the podium back to Dr. Advincula.
Thanks, Jeannie. Just want to remind the viewers that if you have any burning questions as you're viewing this webinar, please go ahead and type that in the Q&A link, and we will try to address those in real time. One of the first things I wanted to sort of ask of the panel, maybe I'll direct this question to Dr. Hur first, is when I was reviewing some of the responses from the registrations, one of the things that I noticed was a sort of common theme in terms of questions or just observations was this sort of diagnosis issue. And many were discussing sort of how their diagnoses were sort of drawn out and delayed. So Hye-Chun, is there a point in a patient who doesn't have a definitive diagnosis of endometriosis yet, where you say we have to go get a definitive diagnosis and do surgery? What are the triggers that you look for to not let this drag out and to come up with a diagnosis earlier rather than later? Because as you know, a lot of times women, it's 10 years before they're diagnosed with endometriosis from the onset of symptoms. And so what is your normal practice?
I think as we had highlighted earlier, the diagnosis is made through surgery. And so ultimately, and unfortunately, there is no blood test or an imaging study that definitively diagnoses endometriosis. So when a patient presents symptomatically with reports of pelvic pain and the potential impact of that pain is impacting their day-to-day function, or they're suffering from infertility, both of those clinical manifestations can be triggers for patients seeking gynecologic care to then undergo the definitive diagnostic test, which is really a laparoscopy. And so for us, for myself and Dr. Kim as minimally invasive GYN surgeons, that's often how we encounter our patients and take the next step to undergo laparoscopy. And I think for Dr. Rackow, it may be both pain and infertility that presents. But I think at the end of the day, either the provider through symptom screening or the patient through presentation of symptoms can trigger the request for or suggestion for a laparoscopy. And I do think that there are some providers who will do what we call empiric medical treatment, where without the surgery, they just initiate medical treatment for hormone suppression. If the patient is a responder, we make a presumptive diagnosis. I think although that is not a bad option for certain individuals at a young age where it might potentially impact fertility, and for a highly symptomatic patient, undergoing the diagnostic gold standard for a definite diagnosis could be instrumental for the patient's care.
Well, that dovetails really nicely to a question I have for Beth. At least I'm often asked in my office what to do with interpreting sort of provocative studies like the receptiva test and BCL6 markers that some clinicians will obtain on patients. Do you have any thoughts on how useful that can be for us as clinicians and for patients who may have endometriosis? Beth, I think you're on mute.
So these are tests that are endometrial biopsies that we do in our infertility office that we're often employing to help understand why maybe a patient's having trouble getting pregnant, or we've tried several different treatments and they're not conceiving. And these may or may not be patients with pelvic pain. And these are often patients who don't have a diagnosis of endometriosis. So it's an endometrial biopsy that shows this, this protein that might be associated with endometriosis. And then the question is, what do you do about this? There's definitely a wave of researchers trying to identify non-invasive tests. So can you not have to have laparoscopy to get the diagnosis of endometriosis? And this is one of those tests that we're utilizing clinically. And the question is, if someone has endometriosis, there are different treatments out there. So one option is sometimes these patients just deserve a laparoscopy to look for endometriosis. I think it's very beneficial for someone who's particularly having pain. To sort of have the diagnosis, treat the condition, and see if that might improve their fertility and improve their pain if they have pain. But otherwise, it does give us guidance from the infertility standpoint of using certain medications that suppress hormones like Lupron, and that might suppress endometriosis, and that might help us move forward and help someone conceive. So it's not a gold standard test at this point. I think it always brings up a long conversation about how to handle a positive result, but it might push some patients towards surgery.
That's great to know. And with regards to diagnosis, Jeannie, do you advocate for just solely making the diagnosis on visualization, or in a patient with a new diagnosis, is there a role, or is it important to make sure we have a biopsy?
Yeah, I think that's a very good point. I think with the diagnosis of endometriosis, as Dr. Hur mentioned, that it's there's visible lesions in the pelvis. And, I think there was a study out there that suggested that up to 50% of the time that GYNs can be wrong about what is actually endometriosis. So especially if someone has never had a diagnosis, I think it's critical that there is excisional surgery where we actually take out and send it to pathology, where they do the analysis and confirm that it's actually endometriosis. I do want to also just highlight that I think, you had mentioned the delay in diagnosis, and multiple studies have shown that it's somewhere between 7 and 10 years in terms of the delay. And I think there's definitely various factors, patients not self-recognizing that this may be an issue, not knowing what's normal, not normal, sort of societal expectations. Maybe the clinicians not being attuned, it's sometimes we have busy practices, and we really should take the time to get to the bottom of a certain issue. So I think there's, no fault of any one particular thing, but that these are all challenges in terms of diagnosis. But I think to highlight that if we, as clinicians, sort of take the time to investigate that particular pain and ask questions surrounding, when is it happening, what has made it better, what makes it worse, etc. I think we can sort of get to the point of thinking that this is maybe in fact endometriosis, and consider laparoscopy, or as Dr. Hur mentioned, considering medical therapy to treat that.
Hey, Chun, if you take somebody to the operating room and you diagnose endometriosis and you excise it all, is that patient cured, or do they still need follow-up? I mean, what should we be doing management-wise for somebody who has manageable surgical level of disease, and you've gotten it all, but what's next steps?
That is a very good question. And it's a very important component of patient counseling when we plan surgery. There are two types of surgery, and I think the surgery you're referring to currently is what we call conservative laparoscopic treatment, which means that we do a laparoscopy where a camera goes inside through the belly button. We see the visible implants, and we either cut it out or we burn it to decrease the physical and visible disease burden. Now, for some patients, this will diminish their symptoms, but unfortunately, this kind of conservative surgical treatment is not curative, because as we had explained, the underlying disease process is that it's a hormone-sensitive condition. And so as long as a woman is hormonally active, meaning in the reproductive age group and not yet menopausal, if a woman could develop symptomatic endometriosis once, she certainly could evolve that kind of symptomatic disease state again. And so this kind of conservative surgery is an adjunct to coupling it with long-term hormonal suppression, which is coupled with medical treatment. With that said, I think Dr. Kim, when she was going over her slides of treatment options, what we call definitive surgical treatment, which is removing the hormone source, surgically removal of the ovaries, uterus, and all the reproductive organs. Although it's definitive in the sense that those organs can never be reinserted, so they're permanently removed, unfortunately, it's not always curative. There are some patients who have even ongoing pain symptoms after the more definitive surgery. So hormonal suppression coupled with medication is a key component of that patient counseling.
Speaking of surgery, one of the things that at least I often struggle with when I see patients in the office is the fertility-seeking patient with endometriosis involving the ovaries. And that's always a huge discussion, and rightly so, when you're dealing with endometriomas. So Beth, what are the implications of endometriomas and fertility, and what should patients be thinking about when they see clinicians about this problem, and what should they be on the lookout for?
Beth, you're on mute.
So we are always concerned when we find endometriomas. And for some patients in our infertility office, their first presentation with endometriosis is actually at a screening ultrasound, finding, a 7-centimeter endometrioma on someone's ovary. The larger the endometrioma, we worry that that extent of the condition can actually impair fertility and make it difficult for that ovary to produce follicles and eggs each month, can make it difficult to do IVF and safely retrieve the eggs from the ovaries without, we try not to interrupt and get the, get into the endometrioma. So for large endometriomas, and especially for patients who don't have an endometriosis diagnosis, and for those who may be also having pain in the setting of infertility, surgery is often warranted as a first step to improve the pelvic anatomy, remove the cysts. One of the things we often do is some testing of egg reserve both before and after the surgery, because there is a concern that if a surgeon is not careful in trying to remove the endometriomas from the ovary, that you could potentially damage the ovarian reserve. But with large endometriomas, you also can't go get eggs. So you're caught between a rock and a hard place. But for someone with smaller endometriomas, 2-3 centimeter in size, sometimes removing endometriomas of that size might actually be more harmful to the ovary than beneficial. And there are studies saying, supporting the notion that maybe the endometriomas of that size can stay in place. So it's always important to have a conversation with the patient, assess their pain levels, assess their fertility desires, and decide, is this a surgery that needs to be done or not?
Yeah, I know that with the larger endometriomas, sometimes when we're in there surgically, it's very difficult to remove the cyst, and you end up having to just drain the endometrioma, being cognizant that we want to do as little damage to the ovary as possible. Is drainage acceptable under those circumstances where you have a large endometrioma, Beth?
The problem is when you drain it, if you don't, from the wall is where that the endometriosis is in the wall of the cyst, and the endometrioma fluid is just accumulation of this old blood over time. And the worry is that if you leave the wall in place, a cyst is just going to reaccumulate. So one option is to drain the cyst, remove some of the wall when safe, and sometimes you can do some cauterization or burning of the residual wall, hoping that it will stop being functional as one sort of intermediate option. Of course, like everything, we don't want to cause harm. We want to improve the situation, and we don't want to harm fertility. So we're always walking a fine line. But that's why I think it's important to have these procedures done by expert GYN surgeons who have an awareness of both sort of the endometriosis condition and as well as, helping patients with desired fertility.
Jeannie, I have a question for you, and this is one that I gleaned from some of the comments made in the registrations. What is your approach when you are encountering patients who have potential involvement of, for example, their bowel? They've got pain with defecation. They might even be passing blood with their stools. What is your typical approach? Is this something that you manage exclusively on your own, or is this more of a collaborative evaluation? Can you kind of speak to that issue?
Sure. So certainly when there is a symptom of any sort of pain involving the bowel, defecation, then we sort of really think about the involvement of the bowel, specifically either the rectum or the sigmoid colon, in terms of endometriosis implants. And, I can sort of envision just potentially stage 4 endometriosis where the uterus, the pelvic organs are completely stuck to the bowel. I think this is also part of the evaluation is at the time of the physical exam, not only a pelvic exam, but most times a rectovaginal exam, just to delineate how much mobility there is, and to get more information. Sometimes we use more, beyond just the ultrasound and MRI, sometimes to really see if there's any specific nodules. Sometimes we're able to feel that on exam as well, but we have some adjuncts in terms of diagnosis. And if we're considering surgery, then we work in partnership with our colorectal surgeons. And oftentimes, we do cases jointly where both surgeons are available to do any of the excision, or sometimes it's hopefully not a whole lot of involvement, but sometimes where there has to be bowel resection or some type of resection of the intestines, then we're both available and readily present to be able to treat that patient with one surgery. I think that's critical.
No, that's a great answer. And with that in mind, Hye-Chun, is it a similar approach when it's urologic involvement in terms of the bladder or the ureter, which I know are other areas where endometriosis can become invasive?
Yes, definitely. I think that I always use the analogy of the abdominal pelvic cavity being like a studio. So it's one big compartment and not like a colonial house where you have separate rooms. And so for better or worse, these endometriosis implants can implant anywhere in the abdominal pelvic cavity, including the bladder system or bowel system. I think a careful screening of symptoms to elicit what symptom profile is manifesting in the patient, and also a coupled very detailed pelvic exam, can sometimes clue us in on whether we feel like we should have a multidisciplinary approach to the surgical planning. With that said, there are times where we'll do a higher level imaging so that we can plan surgically as well. And that might include bladder dissection and dissection in the adjacent neighboring organs.
I'm going to jump to some of the questions that are coming in live, since we've been able to address some of the ones that came in ahead of time. I'm going to direct this one towards you, Beth. There is a question coming in from a viewer who is approaching 2 years since laparoscopic surgery, and the pain is increasing again, and they're looking towards another round of IVF. So what would typically be next steps or guidance? Would it be better to jump right to IVF if possible, or should they consider jumping back into another surgery? Thoughts?
That's
an interesting one. It's one we run into all the time.
Right. No, exactly. And that's such a, a tough crux to be in. So I think for someone, if the pain is getting so bad that someone can't tolerate another period, or can't tolerate any sort of the procedures during fertility treatments, can't tolerate ultrasound, I mean, clearly someone like that, I think moving towards surgery makes absolute sense, to try to improve, scar tissue, endometriosis, hoping with a lens towards helping pelvic pain. Secondly, I think if someone can handle the pain and it's not that bad, but they're thinking towards fertility, we know that some of the more simple interventions like ovarian stimulation and inseminations for someone who has more advanced endometriosis or scar tissue might not be as effective, and definitely time to pregnancy is not as quick. Maybe a 10% chance per month in general versus IVF can have a 40 to 60% chance per month. So I think for patients with significant endometriosis and pelvic pain, going towards IVF to hope will be a faster track to pregnancy and often shorter time off someone's hormone therapy. And then maybe even the option of freezing some embryos for the future. So I think I would use pain as the marker for surgery first, but if the pain is manageable, I think IVF is usually a good way to go.
Yeah, I would have to agree with that. I think in most situations, we use that as a main guide for us, because although we were able to do fertility sparing and fertility enhancing surgery, it's always optimal to avoid being in there and leaving a fingerprint, so to speak. I always tell patients that every time you go in the abdomen and pelvis, there's always a chance you're going to leave a fingerprint, meaning some adhesions. And so if you can get away without surgery to favor the fertility side, it's that tug of war that Dr. Hur mentioned earlier, and it really does summarize the dilemma, the conundrum that we have a lot of days. So let's jump to another question. Jeannie, this one's for you. In terms of what are the chances of endometriosis returning after a hysterectomy if there's ovarian retention? So the ovaries are retained and the uterus is now out. How do you counsel your patients with regards to that question?
Yeah, so since the way that endometriosis is stimulated by estrogen hormonally, unfortunately, even if you have a hysterectomy, it's the ovaries that produce the estrogen. So there can be recurrence for sure. I think when someone reaches menopause, there's obviously a dip in the estrogen level. And at that point, there may be, some assurance that, hopefully endometriosis is not an active issue anymore. But until then, certainly endometriosis pain can return. But also just to point out again, what I had said before is that sometimes pelvic pain can be from multiple reasons aside from endometriosis. And so it's important to also just make sure that just going through that, just making sure that there are no other components to pain besides endometriosis. So it's important to, still think about, if there's still a lot of pelvic pain, cyclic pain after endometriosis, consideration of even hormonal therapy afterwards.
Yeah. I mean, I think the dilemma often is, on one hand, we want to aggressively remove the hormonal influence, but at the same time, we also know the value that ovarian function brings to a woman's overall health and well-being. And so it's really one of those discussions that are really held at length with patients, and knowing what can be done intraoperatively and how aggressive you can be to get all the disease out. I think these are all important factors that get put into the hopper when we're making decisions. Hey, Chun, a question came through about needing additional surgeries. Is it common to require additional surgeries to remove lesions? To have surgery more than once?
I think that the short answer to that question is yes. So before I go into an explanation, I really want to use this opportunity to emphasize the importance and role of long-term medical treatment for hormone suppression between surgeries. So surgery should not, conservative surgeries where we're looking in laparoscopically and excising implants should be as an adjunct, like as a supplement to the long-term hormone suppression in somebody who's not actively trying to conceive. And unfortunately, even in the ideal scenario where a woman is highly compliant and takes her medical treatment for endometriosis daily, there are patients with recurrent symptoms. So it's not a reflection of a patient's compliance or diligence to their medical treatment. As long as you have your pelvic structures, your reproductive organs, particularly the ovaries that feed this disease state, you can develop symptoms again. That ideally is the trigger for when you would have a repeat surgery as a surgical supplement to the hormone suppression medical treatment.
Let's switch gears a little bit to diagnosis again, but diagnosis in the teen years, because I know there's a lot of discussion, and one of the things that we're always trying to prevent is this lag of the 7 to 10 years between onset of symptoms and getting a diagnosis. Beth, how often are you seeing teenagers presenting and ultimately having a diagnosis of endometriosis early on like that?
So this is a pretty common situation that I'm faced with. I see a lot of patients who have dysmenorrhea or painful periods that is just above and beyond the typical cramps that many adolescents face. And so for these individuals, we're often immediately, like in this group, starting with empiric therapy. Because we know that a number of these patients will do better with hormonal therapies, either birth control pills, progestins, and IUD, et cetera, and might improve. And then if they have endometriosis and they're on hormonal therapy, it's being treated. But studies have shown that 70% of adolescents with pain refractory to birth control pills have endometriosis at laparoscopy. So this is a number that I commonly use to counsel the patients and often their parents when I meet with them. And often if someone's tried one birth control pill, we might try a second or a third. And sometimes patients come to me after trying 5 and say, well, trying a 6 isn't going to make a difference. Like, we really need to sort of turn this around and look deeper and consider a laparoscopy. So I think for probably at least 25% of patients who come to see me for dysmenorrhea, it's bad enough that we end up doing laparoscopy. And I would say 90% of them have endometriosis. That it's really common, but we talk about the importance of making this diagnosis early. And then it sort of opens this arsenal of treatments and a roadmap, knowing that now we have a diagnosis. I think it helps, psychologically, it's tremendously beneficial. and then we can move forward. And also an early diagnosis may also have fertility prevention, like it may protect a woman's fertility by knowing that this is there earlier.
Jeannie, one of the questions that's come through relates to newer treatments. And I know that you were one of the principal investigators on the national clinical trials surrounding elagolix, which is one of the newer treatment options available to women with endometriosis. Can you share a little bit of your thoughts on the role that elagolix may play in our treatment armamentarium?
Sure. So, I mean, I think just broadly in terms of medical treatment options, like I said before, unfortunately, outside of non-steroidal anti-inflammatories, most of them are hormonally targeted. And so I think, treatments, there are different kinds with different side effects. And so I think it's really helpful to have additional medications or treatment options. And so I think it's really important sort of on a national level to continue these research endeavors to discover or provide more treatment options, hopefully medical treatment options for our patients. So just briefly in terms of, I think a lot of people have heard of Lupron, which is a GnRH agonist, and that's an injection where you can either get it monthly or every 3 months. And there's some, side effects because it mimics the menopausal state. So there's hot flashes, vaginal dryness, etc. I think the goal with the GnRH antagonist, and so the only approved one so far is elagolix, and there are other ones in the pipeline. So there's linzagolix and relagolix in clinical trial. And, with these class of medications, hopefully it just provides another medication option for our patients. But like anything else, there are some side effects as well, in addition to the hopeful benefit of decreasing pain. I think the target was essentially to try to minimize the hot flash rate. So I think it's a lot less than the typical leuprolide injections. But still, it's hormonal, so you can't get pregnant while you're on it for sure. And potential hot flash, headache, some GI discomfort. But I mean, you can sort of also find that in so many of these drugs. So there's no perfect treatment, but I think it's just important to continue the advocacy and the research that has to follow so that we can get better treatment options.
Hye-Chun, what do you do clinically when you are confronted with a patient who has a contraindication to being able to take some of these hormonal treatments? So one of the questions that came across related to treatment options in folks who have other conditions, for example, if they have a factor V Leiden, or maybe they've had a thromboembolic event in the past. How do you address that? Because I certainly know that we see those patients in our practices. What do you do?
Yeah, I think you raise a really good point, which is every treatment plan should be tailored to the patient's medical profile and their risk factor profile. So for patients with a factor V Leiden mutation or any sort of inherent risk of developing a clot or thrombotic event, those are the patients that we specifically want to avoid certain components, such as the estrogen component. And so there are certain coexisting medical conditions for which we specifically tailor the medical plan. And in that patient profile specifically, we tend to select either a treatment course like Lupron because it doesn't stimulate the estrogen component, or a progestin-only therapy because it doesn't have the estrogen component. But there are some patients specifically with like migraine headaches, for example, where a specific medical treatment might be favored over another one because it can do what I call double dip. It can comprehensively address not just endometriosis, but their other needs. So if a patient is in the reproductive age group and has contraceptive needs, we'll pick a certain medication. If they have migraines and have endometriosis, I'll pick a certain medication. And if they have a thrombotic risk factor, like the factor V Leiden mutation, we'll pick a certain medication. So it's really important for the patient to go over their medical and surgical background to tailor the plan.
No, that's great. IUD, Mirena IUD, Beth. Good, bad? Does it contribute to inflammation? It's one of the questions that came through. And what about its role in like a teenager, where you've diagnosed endometriosis and you have a 17-year-old who's been having a lot of difficulty controlling symptoms? Thoughts?
So I think IUDs are a great option within our armamentarium or in our toolkit for treating endometriosis. Especially the ones, and so we really prioritize the ones that release the hormone progesterone, and it releases progesterone in high quantities to the pelvis and to the uterus, but there's minimal absorption systemically. So it's great for someone who's had serious side effects in the past on birth control pills or hasn't had their pain well controlled on birth control pills or other oral therapies. And it's also an excellent contraceptive device for those who are interested in that benefit as well. One of my concerns is that with an IUD in place, the ovaries are still making hormones and still making estrogen. And that can still fuel some endometriosis. We know that women with IUDs can still produce, cysts and follicles and eggs on the ovaries. So I often combine, depending on the patient, I often combine an IUD or Mirena IUD with some oral progesterone medication like some norethindrone. And I find that those two together tend to work very well for a lot of my patients. So it's one of the options for my adolescents. And I'm often, for patients where I think they have endo, I'm offering IUD insertions for the adolescents in the operating room because some of them can't tolerate it as well in the office.
No, that's good. That's good to know, because I know it often comes up as a discussion is how early can you place an IUD in somebody who's a good candidate. Speaking of sort of long-term treatments, because the IUD, obviously Mirena, 5 years, you can have it in place. One of the questions that's come across, and I'll kind of throw this out there to the whole panel, is birth control pills. If you're on it, how long can you be on it? Can you stay on it indefinitely until you hit menopause if it's working and you're symptom controlled?
I'll jumpstart the response and then let the others piggyback. But I would say that among the treatment options, it's probably one of the most flexible and best used treatment courses, because it's for somebody who wants to conceive but doesn't have a timeline in mind. It's quickly reversible because it's daily dosing. But there are certain medical profiles that we would restrict use for. So smokers above the age of 35. And as we had mentioned earlier, certain medical risk profiles where estrogen could trigger their medical condition, such as poorly controlled high blood pressure, chronic medical conditions that are that predispose somebody to forming blood clots in their legs or lungs called DVT or PE, or if they have certain migraines with aura. Those are some medical contraindications to using oral contraceptives. But outside of that, it's one of the treatments I use most frequently, particularly for patients who are actively trying to reproduce. It just, unlike the injectables, it's quickly reversible, and it really allows a lot of flexibility in letting the patient jumpstart the next step.
Yeah, I'll say that I don't think there's like a time limit per se with birth control pills. I think there's enough data to suggest that it's a safely used medication as long as there's no other contraindications that Dr. Hur mentioned. I think the only sort of consideration as women age, become, move on to their 50s, et cetera, it's just the risk of possible venous clot, as you all mentioned. And I think it's just a conversation with our patients. If there is a concern or you don't want to take that risk, potentially converting that to a progestin-only option. And I mean, I do have patients who just love the birth control pill, and even at age 50 want to hold on. I think there's potentially just the issue is that sometimes the patients themselves won't know if they necessarily go into menopause. Especially if they're taking it so that you skip the placebo week so that you just go continuously. It's almost like hormone replacement therapy. And so I think sometimes just maybe considering just coming off for and seeing if you actually get a period, just to make sure that you're not giving someone who's postmenopausal additional birth control pills.
Any thoughts, Beth? Or
So I agree with everything Dr. Hur and Dr. Kim said. One of the things I like about the birth control pills is there's like 100 different ones out there. So you can really tailor the therapy to the patient based on side effect profile and desires, et cetera. Unlike everything else where there's, one type of Lupron and one type of a GnRH antagonist and very few IUDs. So I feel like it really, there's a whole arsenal there for you. But I definitely, and as women get older, we can also tailor the therapy by lowering the dose. We don't have to be on such a high dose pill. We can start to drop the dose back if we think that that's more reasonable as women do get older, or if we have other medical conditions that we need to be concerned about.
this sort of leads into one of the questions that came up this evening about sort of which of the medical treatments is safest with the fewest side effects and most effective. And I think the answer to that is it's all customized. I think if I could, probably speak on behalf of the panelists, it's probably more of a customization that allows us to determine for this given individual, this is probably the safest treatment with the fewest side effects and is most effective. But in another woman, it might be a completely different treatment that fits that bill. And so I don't know if there's really a one size fits all, at least based on listening to the perspectives that the three of you just gave. We're rounding out in terms of the last 5 minutes of our webinar. I can't believe how quickly the time has gone. But I wanted to take this time to kind of give each one of you an opportunity in a minute or two, just to kind of share what you believe are some important take-home points for our viewers out there. I know we've got a lot of questions and I tried to get to as many as I could, but I also wanted to give our panelists an opportunity to kind of share take-home thoughts before we conclude. And I'll start with you, Jeannie.
Yeah, I think you hit the nail on the head with just that treatment is extremely personal. I think it really depends on the patient with the symptomatology, the history, what treatments have worked in the past, their fertility goals, their pain goals. I think it's, there's no one size fits all, as you said. And so I think this is an important factor to discuss with your provider in terms of what the goals are and where you want to be. So hopefully you can come to a sort of an effective treatment. But sometimes in medicine there's no perfect solution.
Hye-Chun?
Yeah, I would say that for patients in the reproductive age group who have a diagnosis of endometriosis, diligence to the medical management coupled with intermittent surgical treatment is important. And to achieve that balance, having a longitudinal provider is equally important as the patient being a self-advocate to their symptom profile. And I would say that there are times when patients say they're doing okay, but then I do the pelvic exam and they're jumping off the table. And objectively, I can tell that their disease state has heightened. And there are other patients who say it's terrible, this medication's not working, but they used to jump off the table when I did the pelvic exam and they're talking through the whole exam. And so I think that open discussion where you have an objective eye through the exam or through symptom reporting from the patient and provider is really important, and maintaining a continuity OB/GYN doctor would be essential for that ongoing conversation.
Beth?
So I think I've already worn my adolescent GYN hat quite a bit about sort of early detection and early management. So wearing my fertility hat, I would say that women who have a known diagnosis of endometriosis, who are under therapy, because this piggybacks off what Dr. Hur just said, I think as they're starting to think about conceiving, I think it makes sense to have a consultation with a fertility specialist at that time to understand what it means to potentially stop a medication that's been controlling your endometriosis and your symptoms and then trying to conceive, and even potentially undergoing some fertility testing for you and your partner, if there is a partner, to make sure there's no roadblocks in the way before you think about conceiving, and having a very a detailed plan about how to move quickly from coming off endometriosis treatment to hopefully conceiving. Because the hormones of pregnancy, with being progesterone dominant, is actually a great treatment for endometriosis. So I think that is important, sort of the early management of the concern for infertility in patients with endometriosis.
And I'll just add my final two thoughts on this subject. And that is to say that this is probably one of the most complicated conditions that we manage as gynecologists. And, you know, in 20 plus years of practice, the one thing I can say is that it is extremely important to be able to collaborate and work with other clinicians. And I certainly have the honor and privilege to work with the folks on this panel to address some of the cases that we see. It's complicated. It requires a lot of conversation with patients, understanding their goals. And I really do think that that analogy of the tug of war, we struggle every day with this balance between controlling pain and improving quality of life, and balancing that with the desire for fertility, if that's something that a patient has. And so being able to work collaboratively with clinicians who can help navigate that, I think, is extremely important. And especially when the disease involves other organ systems, I think that's really where it becomes additionally extremely important. And so sometimes we don't have a cut and dry perfect answer. And I think the take home that I think all of us came to a conclusion with today is that it really is a customized treatment plan that we incorporate with patients all the time. And we base that on, as Jeannie said, you know, history, physical, past surgeries, past medical treatments, and try to come up with sort of the ingredients that come together to help get people to where they want to be. I know that we've come to an end. I just want to thank our viewers for patching in on a weekday evening. I know everybody's often busy and trying to make a 6 p.m. webinar. It can be difficult at times, and we had a great turnout. And I do want to pass on that this has been recorded, and so the webinar and I believe the slides will be shared with those who have registered for the webinar. So I know some people patched in a little bit late and missed the beginning, so you'll be able to get access to that in the future. And I think with that, I'll conclude. I just want to thank our panelists again for joining us this evening and sharing their clinical expertise. And again, on behalf of Endometriosis Awareness Month. Thank you all.